This narrated presentation contains different cases you may encounter in a long-term care facility. We will review some cases and make decisions about residents in the long-term care facility based on your previous knowledge and on information introduced in this presentation. By the end of the presentation, you will be able to explain that collecting a good microbiologic specimen is important to determine whether a resident needs to be treated with antibiotics. You will also be able to detail procedures for collecting urine and respiratory samples from nursing home residents. Finally, you will be able to describe strategies that reduce the risk of collecting contaminated microbiologic samples. The overall goal of this presentation is to help you collect high-quality samples, which will lead to better decisions about antibiotic prescriptions for your residents. Let's start by looking at a case. Clara is an 86-year-old resident who is in your facility for physical therapy after she broke her hip. Today, she tells you it burns when she urinates, and she feels like she always has to go. You tell the provider about Clara's pain with urination, dysuria, and urgency. She asks you to collect a urine sample for urinalysis and for culture. Let's take a minute to review our indications for collection of urine cultures. Residents who do not have urinary catheters and develop new pain with urination or dysuria should be evaluated with urinalysis and culture. Incontinence or urgency alone is not an indication to obtain a urine culture. This is a common symptom in the elderly and does not necessarily indicate infection. Clara did report new pain with urination, so it is indicated to obtain a urine specimen for further analysis in this situation. Unfortunately, Clara does not think she can stand long enough to get a midstream, clean-catch urine sample of her own, which would be the preferred method of collection in this instance. This is often the case for residents in nursing homes, so let's discuss some alternatives for collecting the urine if these midstream specimens cannot be collected by the resident alone. Take a minute now to think of some alternatives to collect the urine in this situation and consider the pros and cons of each. Then we will discuss the possibilities. One option would be to offer to help Clara catch the urine while she urinates. While this seems like a good idea in theory and does not require invasive techniques, this method is likely to lead to some bacterial contamination from her skin. An option here would be to offer to help the resident take a shower or bath prior to collection to ensure her genitals are clean. Next, make sure that you allow the resident to void the first portion of her stream before you begin collection. This will minimize the bacterial load from her skin. The next option, giving her a toilet hat to collect urine, also runs the risk of obtaining a contaminated specimen. Toilet hats are great for measuring ins and outs, but are not usually suitable for collecting urine for culture. Collecting the urine in a clean, sterile container is important. Toilet hats are not sterile. The urine will be contaminated with bacteria from her skin and could be contaminated by the toilet hat itself. By the time toilet hats are in position, used to collect the urine, and removed, they will have bacterial contamination. So the urine that is transferred from the hat to a sterile container will become contaminated. Last, obtaining an in and out catheterization is probably the best way to obtain a good sample. The downside to this approach is that it is invasive and can be uncomfortable for the resident. Again, using sterile technique and cleansing the genitals before obtaining the sample remains important here. Let's consider how the previous case would change if the resident was a man. With male residents, it remains important to clean the skin around the genitals to reduce bacterial contamination. It is typically easier to obtain a midstream specimen in men, but if this is not possible, then consider placing a condom catheter rather than an in and out catheter to obtain the specimen. Condom catheters are generally more comfortable. After the condom catheter is placed, check the collection bag every 30 minutes. Because this is a newly placed catheter, you can collect the sample from a collection bag that has held the urine for a short time. Regardless of the approach, you can take steps to minimize bacterial contamination of your sample by cleansing the genitals prior to collection, washing your hands, wearing clean gloves, and collecting the specimen in a sterile container. Let's move on to another case. One of the residents you are caring for in the nursing home has a chronic indwelling urinary catheter due to urinary retention and an inability to void independently. He develops a fever with flank pain, and you are concerned about a urinary tract infection. You call the provider on call to report his symptoms, and she asks you to place a new urinary catheter before collecting the sample. Take a moment to consider the reasons she recommended this, and we will discuss the possibilities on the next slide. Let's go through the possible answers and decide if each is true or false. 1. The urinary catheter has been in too long. The urine specimen is not helpful. Is this true or false? This is true. The plastic surfaces on the catheter become coated with a biofilm soon after placement. This biofilm contains bacteria that may not necessarily be related to the resident's new symptoms. A new catheter should be placed before obtaining the specimen. Placing a new catheter can help hasten the resolution of symptoms. This is also true. If a urinary catheter has been in place for more than 2 weeks, a new catheter can help hasten the resolution of symptoms and reduce the risk of subsequent catheter-associated urinary tract infection or bacteriuria. We believe that the reason for this is that removing a heavily colonized catheter may remove the nidus for infection. 3. The catheter should not be changed before collecting the sample. The suggestion must just be the provider's practice pattern. This is false. IDSA guidelines recommend changing the urinary catheter before collecting a urine sample if it has been in place for more than 2 weeks. This is because colonizing bacteria from the catheter can get into the sample and lead to inaccurate culture results. Collecting a urine sample from a new catheter is good practice. In fact, based on our clinical experience, we recommend changing the catheter if it has been in place longer than 24 hours. Here are the reasons why it is important to obtain your urinary specimen from a new, clean catheter rather than one that has been in place for a prolonged period. 1. Rapid colonization. Within 1 to 3 days of placement, bacteria will colonize urinary catheters and coat the plastic with a biofilm. 2. Biofilm formation. A biofilm is a layer of slime secreted by bacteria that protects them from antibiotics, drying out, and other threats. Once the biofilm is formed, it is very challenging to eradicate bacteria without removing the catheter itself. 3. False positive culture. A positive urine culture obtained from an indwelling urinary catheter may grow bacteria that came from the biofilm. Bacteria from the biofilm do not usually cause problems for the resident and are not necessarily representative of what is going on inside of the bladder. Now we will review a short video to describe the correct method to obtain a urine sample from a clean, newly placed catheter. It is acceptable to collect urine from the port of a freshly placed catheter, not from a catheter that has been in place for a long time. We recommend removing the catheter and placing a new catheter before obtaining the urine specimen.
For urinary specimen collection, if there is no visible urine in the tube, you will need to clamp the tube for at least 15 to 30 minutes. And to clamp the tube, it's fairly simple. You can clamp it just below the port where you're going to be taking your specimen. Just bend it in half, and you can put the clamp from the bed on it, and that should be enough so that the urine will back up into the tube. Do not let it go any more than about 30 minutes. Once I see urine in the tube, I am going to open up an alcohol wipe, and I'm going to wipe that surface. Circular motions. Let it air dry for a minute. And take a 10 cc syringe with a 25 gauge needle on it. You want to then be able to insert, I'm using a larger needle at this point so you can visualize it, but you need to insert it in at an angle. Once you get it in at an angle, then you draw back the desired amount. Usually it is 3 to 5 mils. Remove your syringe, unclamp the catheter, take your sterile specimen container, make sure that the lid stays in a downward position, insert your urine into the tube, flip up your safety cap on your needle, screw the cover on, make sure that you date, label, and time this. It needs to get to the lab within 15 minutes to remain viable, and so that bacteria does not grow.
Let's review the procedure to collect urine from a catheterized resident. If a catheter has been in place for more than 24 hours, we recommend placing a new catheter and obtaining the specimen from that catheter. Wash your hands and change to new sterile gloves before placing the new catheter. Obtain the specimen in a sterile container and label and transport the urine promptly to the lab or the refrigerator. Now it's time for a quick knowledge check. Try to think about the correct answer to these questions, and then we will review. First, why do you need to wash hands and change gloves before a new catheter is placed? You just removed a contaminated catheter. If you don't wash hands and change gloves, you will immediately transfer bacteria to the new catheter and contaminate the urine specimen. Second, why is it important to refrigerate the specimen if it can't be transported to the lab within 2 hours? Specimens that aren't handled properly are at risk for bacterial overgrowth and should not be accepted for analysis in the laboratory. All that hard work obtaining the urine sample will be useless if the specimen isn't stored and transported appropriately. Here are our take-home messages regarding good urine sample collection. Always help residents clean the periurethral region for a clean catch specimen prior to collecting urine. If midstream clean catch specimens are not possible, perform an in and out catheterization for female residents or use a condom catheter for male residents. If a catheter has been in place for greater than 24 hours, we recommend placing a new catheter before obtaining a urine specimen. Always wash your hands and obtain the specimen in a sterile container. Transport urine samples promptly to lab. Refrigerate if it cannot be transported immediately. Let's move on to discuss sample collection of respiratory cultures. One of the residents in your facility develops a new cough and a temperature elevation of 100.4 degrees Fahrenheit. She appears ill and reports being short of breath. Orders are placed to obtain a sputum sample and chest X-ray to evaluate for pneumonia. Before we move on to discuss the best way to obtain a sputum culture, what else do you think would be a good idea to send as part of the workup here? A CBC with differential could help to determine if the resident had leukocytosis or a high white blood cell count, which could be a sign of a developing infection. Urine Legionella and Strep pneumoniae antigen are great rapid diagnostic tests that can help evaluate for common causes of pneumonia quickly. If one of these tests is positive, it can also help to choose the right antibiotic early on, which is a major benefit for the resident. Rapid flu. This test is always recommended during flu season from October through March. Flu is very contagious, and if we don't monitor for it, an outbreak can occur in the facility. Urine culture. The resident has symptoms of cough and fever with no complaints of urinary symptoms. Without urinary symptoms and another good reason for fever, we would not recommend obtaining a urine culture. Now you walk in the room in the late afternoon and ask the resident to cough and spit in a cup. She coughs twice, a dry cough, and then spits some clear fluid into the cup. You transfer the fluid from the cup into a sterile container after giving afternoon medications to the 3 other residents you are covering for, and then send the specimen to the lab. 2 days later, results from the specimen you sent return from the lab. The results read, insufficient sample, normal respiratory flora. At this point, the resident has had her chest X-ray, which shows a right lower lobe pneumonia. Her flu swab was negative, but she continues to cough. She was started on broad-spectrum antibiotics because culture results are not available to tailor the therapy to the bacteria growing in her lungs. Let's consider how you could have prevented this from happening and improved the likelihood of obtaining a good sputum sample the first time. Sometimes it helps to explain to the resident that you are trying to obtain a specimen deep from their lungs, so they understand you do not want them to just spit in the cup. The specimen should be collected directly into the sterile container. Transferring it from a non-sterile cup defeats the purpose and can risk contamination. Finally, the specimen should not sit around after collection. It should be sent to the lab as soon as possible. Here are some suggestions to help collect a good respiratory sample. 1. Obtain an early morning specimen. Often residents are better at coughing up a good specimen in the early morning hours, so we recommend obtaining specimens at this time when possible. 2. Wash hands and use new gloves for specimen collection. 3. Ask the resident to rinse her mouth out with water before collection. This helps to remove some of the loose cells from her mouth and may reduce contamination of the phlegm. 4. Explain to the resident that you need phlegm from her lungs, not just spit from her mouth. If the resident is unable to cough up a specimen, you can give a treatment with aerosolized saline to induce a deep cough. 5. Collect the specimen in a sterile container. Transferring it from a cup can increase the risk of contamination. 6. Transfer the specimen to the lab promptly. If the specimen sits for too long, the bacteria may die before being cultured. While the resident in the previous case clearly had evidence of pneumonia with a new positive chest X-ray, fever, and cough, we must remember that bacteria do colonize our mouth and upper respiratory tracts, and a positive sputum culture must be interpreted based on the clinical presentation. Sputum cultures should only be sent on residents for whom you are concerned have a lower respiratory tract infection. A positive sputum culture does not necessarily mean that that organism is responsible for infection. Remember that bacteria and yeast colonize our mouths, and these can be captured if you do not obtain a good deep sputum specimen. For example, we often see sputum cultures positive for yeast or Candida albicans. This almost never causes pneumonia and should not generally be treated. Sputum cultures should not be collected on residents with bronchitis or COPD exacerbations. These are often caused by viral infections, and the sputum culture will likely represent colonizing bacteria rather than an underlying infection. Here are some general take-home messages from this culture collection module. A resident should be symptomatic before we start collecting samples to send to the microbiology laboratory. Bacterial colonization does not necessarily represent infection, and a good microbiologic specimen can help make the correct diagnosis and direct treatment. So following the correct procedures and sterile technique is very important for the well-being of the residents in your facility. The findings and recommendations in this narrated presentation are those of the authors, who are responsible for its content and do not necessarily represent the views of the Agency for Healthcare Research and Quality, or AHRQ. No statement in this narrated presentation should be construed as an official position of AHRQ or of the U.S. Department of Health and Human Services. Any practice described in this narrated presentation must be applied by healthcare practitioners in accordance with professional judgment and standards of care in regard to the unique circumstances that may apply in each situation they encounter. These practices are offered as helpful options for consideration by healthcare practitioners, not as guidelines. Use of brand, manufacturer, or vendor names is for identification only and does not imply endorsement by AHRQ or the U.S. Department of Health and Human Services.